Topic that I will be discussing today is medical complications of spinal cord injury. I am Dr. Sneha Shanbag, internist at DPRC. I will be discussing this topic under the following headings: epidemiology of spinal cord, anatomy and physiology of the spinal cord, levels of injury, and the medical complications. The medical complications can be DVT, pressure sores, autonomic dysfunction, orthostatic hypotension, sexual dysfunction, etc. So coming to the epidemiology, the incidence of spinal cord injury, if you look at it, it's around 10,000 new cases of spinal cord injury every year. These are USA-based statistics. Prevalence is around 200 to 250,000 cases per year. If we look at the gender, 82% are male and 18% are female. If we look at the age, the average age of injury comes to around 31.7 years. The common causes are motor vehicle accidents, which is around 44%, violence, which is because of sports and falls and etc., is around 24%. Characteristics of injury, if we look at tetraplegia with C5 level injury, paraplegia with T12 level injury. Common demographics are fewer years of education, more likely to be unemployed, and more likely to be single. Now coming to the anatomy of the spinal cord, we know that the spinal cord extends from the lower end of the brainstem up to the coccygeal region. It has 7 cervical, 12 thoracic, 5 lumbar, and 5 sacral vertebrae, which are then fused, and then there is coccygeal vertebrae too. And if we look at the cross section, we know that there is gray matter and white matter in the spinal cord, and then there is a dorsal root and ventral root which join to form the spinal nerve, which then splits into the ventral ramus and dorsal ramus. When we look at the physiology, we know that there are ascending tracts and descending tracts, and all of them are important in relaying information to the brain and executing information from the brain. And every dermatome in the body is on the skin is supplied by one particular spinal nerve, and that helps us in good localization of the motor and sensory level of injury. Now coming to the medical complications of spinal cord injury, we start with orthostatic hypotension. As the name goes, orthostatic hypotension. So when the patient stands, he feels dizzy. This is a state of transient reflex depression. The causes are because of lack of sympathetic outflow, which is triggered by tilting patient to more than 60 degrees. Even tilting patient to more than 60 degrees in a patient with spinal cord injury can cause orthostatic hypotension. He doesn't need to really stand. Lesions, generally it happens in lesions which are T6 or above, because the heart and blood vessels are supplied at that level. Mechanism of action is upright posture triggers the hypotension. Brainstem is unable to send a message through the spinal cord. Vasoconstriction of splanchnic bed, and then the patient starts feeling very dizzy. How can we help in this orthostatic hypotension? By repositioning, elastic stockings, abdominal binder, ACE wrap. We can even give salt tablets around 4 times a day. Most of our patients we know are on midodrine or ephedrine, which are alpha agonists. Fluid resuscitation in very severe cases. And we know that generally this orthostasis lessens with time due to development of spinal reflexes. The next thing is autonomic dysfunction. Autonomic dysfunction. So generally the autonomic system has to function in a certain way, and when it doesn't function, we call it as autonomic dysfunction. This condition is very specific to spinal cord injury. The onset is after spinal shock within the first 6 months to 1 year. Incidence is around 48 to 85% of patients with spinal cord injury. Causes are noxious stimulus below the level of lesion causing massive imbalanced sympathetic discharges. So the lesions could be T6 or above. What happens to the patient with spinal cord injury is that he develops headache, flushing, piloerection, sweating above the level of spinal cord injury, blurry vision, nasal congestion. If we see a patient developing all these symptoms, we should think of autonomic dysfunction. Along with this, when you check the blood pressure, it is going to be very, very high. So common causes are bladder, which is blocked because of catheter. The causes related to bladder, which is blocked catheter, related to bowel, which is fecal infection, pressure ulcers, ingrowing toenail, urinary tract infection. There's always a cause for autonomic dysfunction. And the first line of treatment would be to identify the cause and relieve it. Once that is done, the blood pressure settles and the patient's symptoms go away. Treatment: make the patient sit up, remove tight clothing, abdominal binder, remove noxious stimulus. Nitroglycerin can be given to control BP, nifedipine can be given, hydralazine can be given, clonidine. Some patients might require even ICU support and some might even develop complications of hypertensive injury, hypertensive emergency like subarachnoid hemorrhage, retinal hemorrhage. But generally, the first line of treatment is to make the patient sit up and remove the noxious stimulus. This itself helps the patient. Next, coming to the bladder dysfunction. So the bladder dysfunction is of two types. There is element type of bladder injury and UMN type. Element type is failure to empty. UMN type is failure to remain full. So when there is failure to empty, the bladder goes on filling up. And since the internal sphincter has increased tension, so the patient cannot open up the sphincter and void. So the bladder fills up and the patient has to either give pressure from above to push the urine out. UMN type of bladder is the opposite, where the bladder cannot store and it continuously keeps contracting and patient keeps passing small amount of urine. There is no suppression of micturition center, hence the patient keeps voiding prematurely. Then the common ones are combination type of bladder, which is detrusor sphincter dyssynergia syndrome. Common causes for this particular condition is central cord injury, multiple sclerosis, or progression of any spinal cord injury can end up with a DSDS. Lesion could be S2 to S4 and it can also be in the pontine micturition center. So now what do we get? We get a tight little bladder with a tight sphincter. So the bladder continues to contract and cannot fill fully. At the same time, the sphincter is also tight and the sphincter doesn't give way. So the patient has this contracted bladder with extreme urge to pass urine, but he cannot pass. The treatment would be anticholinergic medications to expand the detrusor, intermittent catheterization, antimuscarinic drugs to cause bladder relaxation, alpha blockers, and sphincterotomy. We have seen in our patients that most of the time the anticholinergic meds and the intermittent catheterization help the patient. Another problem with the bladder part is the recurrent urinary tract infections. Most of the time they are asymptomatic. The WBC count, if it is less than 50 in the urine and the patient does not have any symptoms, we don't treat this urine infection. We treat it when the patient does not have symptoms only in presence of vesicoureteric reflux or hydronephrosis. Symptomatic UTIs, when the patient has fever, abdominal pain, burning sensation while passing urine, that has to be treated. Sexual dysfunction. Sexual dysfunction can happen, generally it is described in males with erectile dysfunction. It can be reflexogenic or psychogenic erections. They are more common in incomplete spinal cord injury lesions. Patients can sometimes maintain erection on stimulation, but that is insufficient for a sexual satisfaction. Methods to induce erection are sildenafil, intracavernosal injections, penile vacuum device, penile implants. Then the other type of dysfunction can be ejaculatory dysfunction, which happen because of incomplete upper and lower motor neuron lesions. Methods could be to induce ejaculation in the form of intrathecal neostigmine, subcutaneous physostigmine, and direct aspiration of the sperm. The other issue with sexual dysfunction is infertility, which is common in males and females. In males, the quality of the semen itself is very poor because of stasis of prostatic fluid, testicular hyperthermia, recurrent UTIs, and the kind of bladder management that we are doing for this patient. Everything affects the semen quality. In females, you can have temporary amenorrhea, but menstruation can return to normal after 6 months. Females are generally fertile. Birth control measures are also, we need to think when a lady with a spinal cord injury wants to have a birth control method so that she does not have to face pregnancy. Then oral contraceptive pills can be given, but we know that it can cause venous thromboembolism. Intrauterine devices can be put, but then they can cause autonomic dysfunction. Pregnancy in a patient with spinal cord injury is possible, and it can be complicated with urinary tract infection, leg edema, autonomic dysreflexia, constipation, premature birth, and then lot of complications during the delivery. Gastrointestinal complications and bowel management. First is about defecation. So we know that most of our patients, as we see with spinal cord injury, are always constipated. So there are two things. UMN lesions can cause a hyperreflexic bowel, where there is decreased ability to sense defecation and stool can be propelled by reflex activity. So in these patients, patient passes stools sometimes on irregular basis, but it happens without the patient's knowledge. And in element lesions, the reflex defecation is absent and the patient is always constipated. Management of constipation. Diet, first is diet modification with high fiber. Medicines like psyllium husk, Ducosate, suppositories can be given. Bowel diversion is done for incontinence. And then you can also give enemas, regular enemas for these patients. Gastroesophageal reflux can also be a problem with patients with spinal cord injury. We avoid prolonged recumbency. If the patient is smoking, we have to make sure that we explain about this. And medicines like calcium channel blockers, Valium, nitrates can also worsen the reflux. Gastroesophageal bleeding is also seen in them. Generally, it's because of stress ulcers, if there is a coherent steroid use, and because of increased gastric acid secretion. Cholecystitis is also an abnormal gallbladder motility which is seen in patients with spinal cord injury. Abnormal biliary secretion can also be a problem. Pancreatitis can also happen in these patients because of increased viscosity of secretions. Metabolic complications, hypercalciuria and hypercalcemia. High calcium secretion in the urine. This can happen because of immobilization, decreased weight bearing promotes bone resorption, which results in hypercalciuria. Hypercalcemia is rare. Generally, it's a combination of bones, stones, and abdominal groans where patient comes very dehydrated and complains of severe pain in the bones, and patient has renal stones. Treatment would be to hydrate the patient, mobilize the patient, and decrease the GI absorption of calcium. Osteoporosis is also commonly seen in patients with spinal cord injury. It is because of disuse. 22% bone loss 3 months post injury. Treatment is weight bearing and cycling. Musculoskeletal complications are also known. Shoulder is the most commonly affected joint. Rotator cuff tear is seen, capsulitis, cervical radiculopathy, myofascial pain, subacromial bursitis. Treatment would be pharmacotherapy for the pain and educate the patient regarding posture and weight bearing. Compression neuropathies form around 54% in these patients, commonly seen as carpal tunnel syndrome, and it's even seen 11 to 30 years post injury. Pulmonary complications of spinal cord injury. The incidence is respiratory complications occur around 50% of the patients. Frequent complications are pneumonia, atelectasis, ventilatory failure. Pulmonary dysfunction in the form of paralysis of respiratory muscles, loss of ability to cough, traumatic injury to the chest and lung. Pneumonia is the leading cause of death among spinal cord injury, and improper posture, drainage, altered ventilation are the common causes of pneumonia. Prevention of respiratory complications would be with the help of incentive spirometer, cough assist, suctioning, chest physiotherapy, pneumobelt. Heterotopic ossification, formation of lamellar bone in soft tissue around the joint. Cause is decrease in tissue oxygenation. Incidence is around 16 to 53% of patients. Onset is 1 to 4 months post injury. Symptoms are soft tissue swelling, reduced range of motion around the joint. Risk factors are spasticity, completeness of injury. Now, diagnosis can be done with X-ray and serum alkaline phosphatase levels. Treatment is with etidronate 20 milligram per kg per day for 2 weeks and 10 milligram per kg for 10 weeks. Range of motion is generally affected.